what's new in the cough management? Okay, that's what we have discussed. Now there is this drug called as a gefapixant that I think Merck has got out with. They did some trials, meta-analysis. It's used for moderate, the use of moderate high dose of gefapixant significantly elevated cough severity and improved cough rate quality of life, but there's increased risk of all-cause adverse events. And to the best of my knowledge, in December 23, I think FDA rejected the second application, so it's not FDA approved. Okay, so a lot of research is happening. People are making a lot of efforts, but they still have to convince the FDA to the best of my knowledge. So this is the slide which shows the various drugs that are being under evaluation for the treatment of chronic cough. So clearly, the pharma is interested in looking at a lot of research is going, and hopefully we will have some strong data and good molecules which will help us to treat these patients with chronic cough in a better way. Now, what is it? I mean, is this resource constraints when it comes to treating chronic cough, or they are genuine challenges? And this is a very interesting paper from Spain. They look at the characteristics and management of patients with a refractory or unexplained chronic cough in an outpatient clinic. And what they found is that dominant number of patients are treated with antibiotics, to be macrolide, beta-lactam, cephalosporins, and quinolones. The findings highlight the shortcomings of available treatments, which mainly do not address the underlying pathology of cough. So basically, dominantly treated with antibiotics. And clearly, you see, we look at acute cough, we look at subacute cough, we look at chronic cough. The role of antibiotics is very limited and specific. So we need, because it might be a reflex to initially administer antibiotic for cough, but I think we need to look at the cause of cough, which is extremely important. Yeah. What do the British Thoracic Society guidelines say? There's a chronic cough is difficult for patients and clinicians also. So now let's go a little bit beyond pharmacotherapy and supportive therapy for cough. And, it could be educating patients, using cough suppression techniques. We can involve our physiotherapist. We can involve our speech therapist, do some counseling, identify psychological factors also. What is the evidence for non-pharmacotherapy? The 6 key studies have completed over 1 year have shown that non-pharmacological interventions can help to improve the quality of life and reduce cough frequency, and the duration of therapy can be up to 8 weeks. So now when we talk about acute cough, what is the first thing that comes to mind? Either you have home remedies, you have cough syrups, and you have lozenges. Okay. The traditional and the natural methods are honey, okay, which is used, and then suck lozenges or a hard candy, warm fluids, and gargling and steam inhalation. So these are the traditional approaches that are used for treating cough. So there are different reviews. There are also reviews from the Ayurveda guideline journals, etc. So I think we come to the important aspect of antitussive. Another important aspect, I would say, not the important aspect, another important aspect. Empiric management with antitussive agents may be necessary for symptomatic relief in acute cough. So, what is the point that's coming? In acute cough, you really need to use the antitussives have a good role, particularly it's a post-viral cough, it's an acute cough, and in that scenario, they have a good role. Non-opioid antitussives are preferred in management of acute cough. You want to avoid opioids. Codeine-based preparations are not recommended for acute and subacute cough, but as I told you, sometimes if you're up against the wall on a selected basis, depending on the individual, you might need to use a codeine-based cough. And typically, whenever we are using any of these codeine-based preparations or any from the codeine family, we typically also counsel the patients accordingly. Now, decongestants and demulcents, the recommendation is the routine use of decongestants if your dry cough is not recommended. However, the use of decongestant as a part of a fixed dose combination with antitussive or antihistaminic is associated in cough associated with rhinitis or cold is recommended for a short period of symptomatic relief. So as a fixed dose combination for symptomatic relief, that's what the recommendations are. And the demulcents are safe on oral or topical administration at low doses. So what these demulcents do is they form a coating in the throat and help with the symptom of dry cough. And the evidence of the safety and efficacy of menthol in managing cough is low or moderate in quality, but I think there is enough clinical experience on that. Now, effects of menthol lozenge on nasal congestion and nasal resistance to airflow. I mean, if you look at this, 62 subjects suffering from common cold, the sensation of nasal congestion was greatly reduced in 10 minutes after the ingestion of the lozenge. So this is the paper from 1990, which gave us this particular data. A faster initiation of action and greater effectiveness is observed when antitussive drugs are formulated as syrups than as tablets or capsules, and therefore, the syrups have stood the test of time. So syrups are quite easily accepted as cough suppressants by the public at large. Also, experts reached a near consensus on recommending the use of demulcents such as lozenges in acute dry cough. However, they disagreed on its use in chronic cough patients. So in chronic cough, of course, you need to know the reason. You need to go and you need to find out the underlying reason, and you need to make a diagnosis, systematic evaluation. But in acute dry cough, I think we need. I think the use of symptomatic therapy has huge benefits. So if you look at the summary of guidelines for refractory and unexplained chronic cough, and this was in the Journal of Respiratory and Medical Emergencies, I think. That's at the base here, published last year, Respiratory Medicine and Research. The guideline number 46 is the experts suggest that the clinicians use menthol compounds in chronic cough patients to occasionally control cough. It's a professional agreement on that. In chronic cough patients, the experts suggest that clinicians do not use codeine or antitussives that are usually prescribed for acute cough. So that's where the professional agreement has come. The data is less. So it's a very important and a common problem. I showed you that the prevalence of cough is very high. The satisfaction of patients with the treatments of cough seems to be very low from the data that we've seen, and therefore it's really tough and a challenging thing to treat chronic cough. But we need to make all the efforts and use all these resources in a very proper manner to alleviate the symptoms of cough, and of course identify and treat the underlying cause of the cough. What do the British Thoracic Society clinical statement of chronic cough says? Look at this. Cough hypersensitivity is a frequently overlooked treatable trait for many patients and requires specific treatment, including antitussives and non-pharmacological treatment. So in chronic cough, in chronic refractory cough, you may need to use a combination of things in order to alleviate the symptom of cough. And, it's not, one treatment suits all. We really need to go in a very sequential and additive manner sometimes, as has been highlighted by the other guidelines. So to conclude, cough is prevalent and rising, and diagnosing underlying cause is of prime importance. So I think we can very clearly discuss whether it can be acute, subacute, or chronic cough. We need to identify the cause of the cough. Cough management should have a holistic approach. It's not that one size fits all, so you need to individualize the treatment. Appropriate strategies involve taking into consideration overall patient history, the period of symptomatic presentation, concomitant medicines and lifestyle, and tailoring every prescription according to the patient need is necessary. As I said, one size doesn't fit all. We need to tailor the prescription, and regularly available home remedies.